evening to all. Happy New Year to all. Today we have two case discussions. One is from MCH Trivandrum and the second one is from Lakeshore Hospital. So probably we'll be having shortage of time, so we will start without much introduction. So I would like to hand over the proceedings to the moderators, Dr. Venu sir and Prakash sir. So first we will invite Dr. Fadusman from MCH Trivandrum.
I think Venu sir can start.
Yeah.
Yes. Good evening to all. Warm greetings from Bangalore. Shall we go to the case presentation, Dr. Fahad, please?
Yes, sir. Sharing my screen, sir. Am I audible, sir?
Yes.
The screen is visible, sir.
Screen is visible.
Yeah.
You're audible. You can go
Okay.
ahead.
Good evening, all. Happy New Year. I thank you for the opportunity to present this case. My topic for today is Whipple and cirrhosis, treading on thin ice. So I will discuss the topic with the help of a case. I will be discussing it under the following headings. And as we reach any diversion in the decision-making process, I will try to elaborate on the available evidence from literature. So coming to our case, so this was a 54-year-old firefighter from Kollam. He presented with vague upper abdominal discomfort for 2 months and loss of weight for 2 months in September 2011. So he had occasional right upper quadrant discomfort for 2 months, not associated with food intake, no retrosternal pain or sore brush. He had weight loss, but it was only 3 kgs over 2 months, and he had generalized fatigue also. There was no fever with chills, no jaundice, no vomiting, hematemesis or melena, no constipation or diarrhea. On examination, he's coming to the past history. He's a known diabetic for 10 years on medication, no other comorbidities. Being a firefighter, he has had multiple superficial traumatic injuries from various rescue operations requiring lacerations requiring suturing, and he gives history of breach of protective equipment while handling rescuing patients. There is no other history of previous transfusions, no past history of jaundice. His sleep and appetite were normal. He's not ethanolic. He's not a smoker. He has no family history of any malignancies. Coming to the examination, he was conscious, cooperative, and oriented. He was moderately built and adequately nourished. He had a performance score of ECOG 1. General examination did not reveal any other significant findings. Vitals were within normal limits. And on abdominal examination, abdomen was soft, no hepatosplenomegaly, no other masses. Rectal examination, there was mild prostatic enlargement, no pelvic deposits. Other systems examination was unremarkable. So with this clinical scenario, the patient presented to medical gastroenterology department, and they continued the blood and further workup of this patient. Upon looking at the blood reports, his viral markers, when it was done, the HCV, anti-HCV was found to be positive. And if you look at the biochemical parameters, the HB was 14, the platelet count was 2.2 lakhs. The LFT was normal except for a mild elevation in the SGOTBT. The INR was 1.22, albumin was 4. And the CA19-9 levels was found to be slightly higher, 96.6. So they continued further HCV genotyping. It was found to be HCV genotype 3 with a viral load of 36,600. So then they proceeded to do a ultrasound of the abdomen. And the ultrasound showed that there was diffuse coarse echotexture of the liver. and there was no splenomegaly. So, and there was a grade 3 prostatomegaly. So, HCV-related cirrhosis of the liver. So, they proceeded to continue with plan for anti-HCV treatment, and they wanted to do a endoscopy, upper GI endoscopy, to look for varices or other features of portal hypertension. So, then when they proceeded with the upper GI endoscopy, there was a sudden surprise. Esophagus, there was no varices. Stomach did not show any features of portal hypertension. But when they went into D2, there was a polypoid lesion at the ampulla. They proceeded with the side viewing endoscopy, and then a biopsy was taken. So with this, they referred the patient to us, and we further went ahead with a cross-sectional imaging of the patient. So because this was 2011, I don't have the scroll stack. I have representative cuts. So here you can see that in the D2, sorry, in the D2 there is a prominent lesion, and if you further look at liver cuts, the liver surface, you can see it is not regular. Liver appears a little shrunken. There's not much of splenomegaly. If you look at the pancreatic duct, there is mild prominence of the pancreatic duct. There is no obvious intrahepatic biliary radical dilatation or dilated CBD. So the CT, the radiologist reported irregular liver margins with diffuse heterogeneous attenuation with a few hypodense nodules with well-defined margins, suggestive of regenerative nodules. The portal vein was found to be mildly dilated with a diameter of 13.8 millimeter. They also described the ampullary lesion, mildly enhancing polypoidal lesion in D2 with mild prominence of CBD and main pancreatic duct. So their impression was an ampullary adenoma, but they suggested to go for pathological correlation. So when we looked at the histopathology, the biopsy report came back with high-grade dysplasia. So with this biopsy report, we were having a dilemma as to how to proceed, because if it is just an adenoma, then whether to go for the HCV treatment first or whether to tackle the ampullary lesion first. We had a discussion with the gastroenterologist who did the endoscopy, and he was of the opinion that the appearance was unhealthy and was strongly suspicious of malignancy. So the considerations, like I said, was whether to go for the HCV treatment first or whether to go for tackling the ampullary lesion first. So if we go for the HCV treatment, assuming that the ampullary lesion was having high-grade dysplasia, the HCV treatment usually is a prolonged treatment, can go from 6 months to 1 year. So that will unnecessarily delay the tackling of the periampullary lesion. So we had to weigh back and forth, and we were in favor of going for tackling the ampullary lesion. If you look at the literature evidence regarding surgery in cirrhotics, the overall mortality, this is for general surgical procedures including hernia repairs and cholecystectomy, overall mortality is to the tune of 28%, starting from 10% in child A to as high as 63% in child C. And if you compare it with the MELD score, if you have a MELD score less than 10, the mortality is as low as 9% to as high as 54% with a MELD more than 15. Despite the progress in technology and better understanding of the liver disease, we continue to have this persistently poor outcome for surgery in cirrhotics. But we have various risk assessment scoring systems, like you have the conventional child score, you have the MELD score. Child score uses 5 parameters. MELD score uses bilirubin, INR, and creatinine. Then you have the ASA score, you have the Mayo postoperative mortality risk calculator. So you have various risk assessment scores. It is to be stressed that these scores are not, they are to be used complementary to one another. And if you look at our patient scores, he was a child A patient with a CIRRHOsis score of 5 and a MELD of 9. So an image can speak volumes than all these scoring systems. This is a representative image. You can see that the liver is hypertenating as compared to the spleen. With the portal vein slightly dilated, there are collaterals. So if there is any evidence of portal hypertension on imaging, that is more stronger predictor of risk of decompensation and mortality post surgery than all your risk scores. Our patient, again, patient had an INR of 1.22, platelet count was normal, was 2.2 lakhs, albumin was 4, there was no splenomegaly, there was no chordate hypertrophy, there was no ascites. Portal vein diameter was slightly on the higher side, there were no collaterals. So with these considerations, with a child A cirrhotic patient, we decided to proceed with surgery. And the other logical thing that comes to our mind is whether if a patient is having cirrhosis and portal hypertension and there are collaterals, surgery becomes very difficult. So is there a way to do a TIPS to collapse the collaterals to aid in EC surgery? So if you look at the evidence, the AGA gives some advice, recommendations regarding this. So they say that TIPS is not routinely recommended before surgical procedures in cirrhosis with portal hypertension with abdominal collaterals, but there is some soft evidence to say that you can decompress collaterals, especially when you're going deep into the pelvis and or if you're going for colonic resections to deal with the collaterals. But the absolute benefit is not proven. We did not go for upfront TIPS, and patient on upper GScopy was not having varices. Assuming there will be no collaterals, and on cross-sectional imaging, again, there was no collaterals. If we look at evidence for Whipple in cirrhotic patients, the post-op morbidity is to the tune of 48%, and the mean post-operative stay was 13 days compared with non-cirrhotic patients, but it ranged to as high as 60 days. The mortality is around 9%. If you compare with any large recent series in non-cirrhotics, the mortality is as low as 2%, ranges from 0 to 2%. So this is one large review of outcomes of pancreaticoduodenectomy in cirrhotic patients published in HPV in 2019. So they had around 36 patients of their own, and they reviewed various studies and collected 135 cases. And when they did a review, the overall mortality, like I said, was around 9%, and morbidity was 48%. But if the MELD score crosses 10, then the mortality rises to 23%. So this is from that study. The review, if you look at it, mortality was around 9%, and the length of stay ranged to as high as 60 days. So their conclusion was pancreaticoduodenectomy may be considered in select cirrhotic patients, and a MELD more than 10 predicts increased risk of postoperative mortality. So, and they highlighted that imaging pre-op radiographic evidence of portal hypertension is predicts poor outcomes. The other consideration was whether should we go for a local resection, considering that the biopsy has come back as high-grade dysplasia. So if you look at any the literature regarding local resection versus classical pancreaticoduodenectomies, so there is only limited evidence with small series having heterogeneous techniques, but overall, what is seen is that the lower morbidity of embolectomy is at the cost of a higher recurrence rate and inferior survival. So this is one of the series comparing pancreaticoduodenectomy and embolectomy or local resection from Beggar et al. So if you see in his study, if you compare pathological T1 lesions and having embolectomy versus Whipple. So the R1 rates were shockingly high as 60%. And if you look at the survival, the R1s did not make it, and only around 30% of them were surviving. This is at 3 years. This is another study from MSKCC comparing embolectomy to pancreatic duodenectomy. So one interesting data is that if you have a pre-op diagnosis or a pre-op biopsy of a benign lesion, around 30%, 1/3 of them had malignancy in the post-op specimen. And if the patient had a high-grade dysplasia on the pre-op biopsy, more than 60% of them had invasive malignancy in the final HPR. So that could be because of the sampling error, whether you're taking a deep enough biopsy or not. If you look at the morbidity for embolectomy is to the tune of 31%, whereas the morbidity for pancreatic duodenectomy in that series was around 67%. But what is the trade-off? The trade-off is that the recurrence-free survival, only 1 out of 9 patients of embolectomy made it to 2 years, whereas more than around 50% of the patients who had a pancreatic duodenectomy they were still surviving disease-free at 2 years. So after these careful considerations, we optimized the patient. We had a thorough cardiac evaluation. We optimized the sugars. We had a thorough pre-anesthetic checkup, and then we proceeded with the procedure. We proceeded with the once we went in, we found that the liver was frankly cirrhotic, and there was a 2 centimeter firm sessile growth arising from the periambular region. There was no other evidence of obvious dissemination. The CBD and the pancreatic duct were undilated, and there was minimal ascitic fluid. We proceeded with the pylorus preserving pancreatic duodenectomy with a end to side dunging pancreatic jejunostomy. And during the surgery, we realized that the field was oozy throughout, despite use of harmonic along with the conventional electrosurgical means. And we used an isolated rulim for PJ in view of a soft pancreas, to undilated pancreatic duct, and a high-risk patient. Intraoperatively, we had to transfuse 1 PRC and 3 fresh frozen plasma. So this was the isolated rule loop reconstruction that we did. Isolated rule loop for the PJ. So if you look at evidence for isolated rule loop reconstruction versus the conventional single loop reconstruction, this is a series from Buechler et al. So if you look at it, there is no superiority of an isolated rule loop reconstruction with regard to occurrence of pancreatic fistula. And they have not recommended such a reconstruction. But there is some soft evidence that says that if you do isolated rule loop reconstruction, it allows for early oral feeding and maintenance of oral feeding even if POPF develops. So the idea is that if there is a PJ leak, if the bile can leak through the same PJ site, and the bile can cause further tissue damage, and the infected bile is, also has a high concentration of lipopolysaccharides, which activates the pancreatic enzymes, which can cause further damage. So that is the logic behind the isolated rule loop PJ, but there is very soft evidence to advocate it. So if you look at the post-op course, he had a very turbulent post-op course. He was electively ventilated for 1 day. He was extubated on the POD1. POD1, we found that the LFT was deranged. Bilirubin was 1.7 and 1.1. And the liver enzymes OTPT were elevated to the tune of 526 and 451. The drain was around 300 ml serosanguinous, not fresh blood. But this 300 ml continued to be there for almost per day for around 11 days. The INR was mildly elevated at 1.47. So we initially started with giving FFPs to both tackle the PTINR as well as the ascites, the decompensating liver. And we had to give almost 3 FFPs per day for around 11 days. We did a amylase levels in the fluid on day 3, day 5, day 7, but there was no evidence of any post-op pancreatic fistula. There was grade A DG. We could remove the right tube only after 6 days. On POD 11, suddenly patient had 2 episodes of melena with a 2-unit hemoglobin drop, and there was sudden tachycardia. So we had to look at as to where the bleed is from. We reintroduced the Rice tube and flushed and aspirated, but we found the aspirate was clear. The drain did not have any fresh blood. The FJ, however, when we flushed and aspirated, we found that there was significant amount of fresh blood. So again, we did not proceed with the upper GI scopy at this stage. 1, because the Rice tube aspirate was clear. 2, because it was immediate post-op POD 12 with a HCV positivity. So we did not consider a low insufflation OGD in this scenario. We resuscitated the patient immediately, and then our next consideration was whether to go for a CT angio or whether to go for a conventional angio directly. The thought was that patient continued to have raised INR, and we considered this as a Herald bleed. And supposing patient had a massive bleed, we would the patient would further decompensate, and we might even lose the patient. So with these considerations, we decided that we will go for a straightforward conventional angio. And conventional angio did not show a pseudoaneurysm or a blush, but we decided to go for a empirical coil embolization. So this is the conventional angio picture. So if you see the GDA stump, there is no blush, there is no extravasation anywhere, there is no pseudoaneurysm. Even the SMA was very clean. And further selectively, the splenic artery also did not show any blush or extravasation. And we did a empirical embolization of the splenic artery. After the embolization was done, there was no further fall in hemoglobin. The tachycardia settled, and there were no further episodes of melena. So if you look at the post-pancreatectomy hemorrhage classifications by SGPS, so you have early hemorrhage within 24 hours and late hemorrhage occurring after 24 hours. And you have a further classification into intraluminal, extraluminal, and mixed. So intraluminal may be stress ulcer bleed or a variceal bleed, or if you have a dunking anastomosis, the bleed may be purely into the lumen. Extraluminal may be from erosions by the pancreatic fluid onto the vessels, leading onto pseudoaneurysms or GDA stump. Usually the anastomotic bleeds are usually both intra and extraluminal. So empirical splenic artery embolization is embolization of a splenic artery short of the splenic hilum, so that most of the pancreatic branches are blocked after once you have an episode of Herald bleed. So this is a general algorithm that is followed. So once you have a pancreatic hemorrhage and we localize the bleed, then we go try to go for a CT angio. In the CT angio, if there is an obvious blush or a pseudoaneurysm, we go for conventional angio followed by coiling. If there is no pseudoaneurysm or a blush and the patient is continuing to bleed, then again we go for conventional angio. It might pick blush or extravasation which is not picked on the CT angio. And anything that is picked, we will coil embolize. If there is no pseudoaneurysm or blush also, if the patient is further deteriorating, we will go for a empirical embolization. Further, once the bleed settled, we could not start the FJ early because there was significant ascites and abdominal distension. So meanwhile, we had to give some parenteral nutrition. And patient total received 4 blood and 38 fresh frozen plasma transfusions. Because he was in the fire department, 50 of his colleagues came and donated blood for him. Despite not having a post-pancreatic fistula, we could discharge the patient only on day 42 because of lack of caregivers and for other social reasons. So the final HPR when it came, it was a well-differentiated adeno-CA of the periambulary region arising from the pancreatic duct. And it was a pathological T2N0 lesion. So if you look at the 5-year survival for periambulary malignancies, the node negative non-pancreatic biliary type has a very good survival of around 88% at 5 years. If you look at the node positive pancreatic biliary type, it has poor survival to the tune of 20% at 5 years. You have the other two varieties, that is node positive non-pancreatic biliary or node negative pancreatic biliary type, which have an intermediate prognosis. This is in comparison to a periambulary, the pancreatic ductal adenocarcinoma, whose survival ranges from 10 to 30% depending on node positive. So following up the patient, around a month after the turbulent course was over, we started HCV treatment. This was in 2011. So he was given pegylated interferon and ribavirin. Treatment lasted over 6 months. He continued working as a fire safety officer. In 2019, he had an IC intracranial hemorrhage, and from which he recovered with minimal residual weakness with physiotherapy. So if you look at literature, there is some correlation between IC bleed and HCV. HCV patients are at around 1.6 times higher risk of IC bleed. And depending on the severity of HCV infection, there is a dose response association also. And the possible etiological mechanism that is described is a first in inflammation leading on to pathological changes in the cerebral arterioles. These are studies that indicate the same. So he remains disease-free at 9 years. He had a sustained viral response. He was HCV negative, and the liver function tests were normal, and CA99 also continued to be normal. Recent repeat CCT abdomen did not show any evidence of recurrence. So to summarize, pancreaticoduodenectomy can be done in early cirrhotics with acceptable morbidity. Preoperative risk assessment and discussion of the risk-benefit ratio with the multidisciplinary team as well as the patient is essential for a good outcome. And proactive perioperative management is essential to ensure optimal results. So if you are walking on thin ice, you might as well dance. Thank you.
Thank you, Doctor, for a nice presentation. It was a challenging case. Cirrhotic patient having a high-grade dysplasia, ambulary adenoma, and not getting a malignancy in the pre-op, going ahead with it was a challenging decision. But as you shown in the literature, most of these patients harbor malignancy, which can be proved only after post-operative biopsy. So the decision to go ahead with it was correct, I assume. But could you do HVPG measurement because portal vein was mildly dilated? Could you quantify the portal pressure beforehand for the risk assessment?
HVPG measurement would have been useful. We used the surrogate markers. Platelet was normal, and the upper GI endoscopy did not show varices. Imaging did not show collaterals. There was no splenomegaly. So since there were no other signs to suggest that there was significant portal hypertension, we did not go ahead with the HVPG measurement.
Another thing you could do after opening is having seen a frankly cirrhotic liver, you could directly
measure the
portal pressure using a transducer. The CVP transducer can be used to measure the portal pressure. Again, if it is more than 10 millimeters of mercury, sorry, 13 millimeters of mercury, then you could decide to back out or maybe Ambulatomy can be considered to reduce the risk of Whipples resection. So, when do you say there is a postoperative severe ascites, refractory ascites in these patients and follow-up?
So when you have patients having continued drain output, it is difficult to say whether it is a sequelae of the surgery, whether it is decompensation of the liver. We have to look at the liver function tests also, and if the LFT is also deranged, then we should think in terms of liver decompensation. Then and we can check the drain amylase levels, and if the drain amylase levels are elevated, then it's likely that you have a pancreatic fistula.
My question is, when do you say it is refractory ascites if you have ruled out a pancreatic leak?
If you are not able to take out the drains, I'm not sure of number of days.
Okay, if you have a 10 ml per kg body weight per 24 hours after 4 days, that's the definition of refractory ascites, and it should be treated accordingly. So, how do you manage these patients with refractory ascites?
We can consider giving them albumin infusion, or we can start them on low sodium diet. We can give them diuretics like spironolactone, classic combination, furosemide and spironolactone.
So one of the common cause of mortality in these patients is a postoperative sepsis,
Yes.
Infection of the ascitic fluid. Any modification you make in your antibiotic policy in such patients?
Generally, high-risk patients, better to go for imipenem or meropenem, higher antibiotics, and de-escalate in the post-operative period rather than waiting for cultures. And
what usually you give? How many days in Whipples resection? How many days prophylactic antibiotic you give? And would you modify in patients with cirrhosis?
Generally, we tend to start them on meropenem, and depending on the post-op bile cultures, then we switch over to other antibiotics as per the culture. But if normal post-op course, we generally tend to give for around 5 days and stop. For those with cirrhosis, and if the patient is having persistent ascites, considering the if we have to give a lot of blood products also, and considering they are at high risk for infection, we would consider a more prolonged course of antibiotics. And to repeat cultures also, the ascitic fluid as well as blood cultures to be repeated, and antibiotic to be tailored accordingly.
To reduce ascitic leakage, would you modify your surgical techniques in this group of patients?
We would try to go for ligages more than electrosurgical devices or harmonic to reduce the lymph leak. And generally, we tend to do that.
Okay. And what was your lymph node harvesting in this case?
So the lymph node harvest was not very good. Around 8 nodes were picked, but all of them were 8 out of 8 per night.
So it was not an aggressive lymphadenectomy.
No.
Instead that the patient developed
Yes.
refractory ascites, which indicates that probably the portal pressure was high. Now the topic is open for discussion.
Fahad, I'm Ramchandran.
Yes, sir.
Excellent case and very well managed. Almost 9 years
Yes.
survival, especially in this sort of a case, it's really commendable. But I have a couple of suggestions. One is, have you done a diaglap in this patient? staging lab, laparoscopy.
No, sir. A diagnostic lab was not done in BP.
Probably good.
But it would have been.
Yeah, probably good to put a scope and see the
Liver.
severity of liver disease and varix, especially in these sort of cirrhotic patients. And second, you have mentioned that despite using harmonic scalpel, the field was very oozy. I don't know. So in a Whipple resection, harmonic scalpel, I don't think it is very useful to reduce the blood loss. Maybe you can use that for dividing the mesentery and all. Otherwise, you should go for a precise dissection, identify the blood vessels like it. I don't think harmonic scalpel will really reduce the blood loss. It's just my opinion. Then,
just to interrupt.
Sorry?
But literature says harmonic scalpel and ligature helps in reducing the ascitic leak.
Maybe. And one more, you have mentioned that isolated loop in this particular case.
Yes,
so
sir.
is that your routine practice?
No, that is not our routine practice, sir.
Change it in a difficult case, because you do,
Yes.
especially in a difficult case, probably the best thing to do is whatever you are comfortable with, do that and come out instead of doing something which is complicated. That's my suggestion. I don't know.
Yes, sir. We do not do isolated rule limb reconstruction for all cases, but we do do that for a reasonable number of cases, and we had experience with it previously also.
And also, you have mentioned that if you have done an isolated loop, you will be able to start feeding early. But I really doubt. Actually, most of the ERAS protocol, especially in Whipple, you can start feeding them, especially liquid diet, from day one. You don't have to keep them NPO, even with single loop reconstructions. When they develop DG or paralytic ileus, of course, you are supposed to put a new nasogastric tube. But otherwise, the evidence still says that it's probably better to start them early feeding. And one more.
Yes.
You in this case, you have given lots of FFP. And I don't know, I think whether it is really useful unless patient is having some bleeding or low pressure.
The drain persisted to be cirrhosanguinous, and the PTINR persisted to be elevated, and there was continued ascitically. So to correct the PTINR as well as...
But the peak INR was less than 1.5, no? It was 1.46 or something.
0.7.
But the drain output was mildly sanguinous, sir.
I would like to ask the expert opinion. Venu sir, what is your thought on this?
I wouldn't correct that level of INR. If there is cirrhosanguinous or suspicion of bleeding, I would go for a tug and see the what coagulation abnormalities there. Correct accordingly, not blindly.
2011.
Yeah. Probably I think we should fill him with more of albumin and take care of his nutrition. Probably that is more important in the post-op instead of giving plasmas.
Yeah.
Maybe my opinion.
We did give TPN, sir. Until the FJ could be initiated, we did give parenteral nutrition, sir.
Okay, or maybe albumin. I think just to fill him up and to reduce the Venu sir was telling about the ascites. So probably to reduce the ascitic fluid, it's probably better give albumin.
Mainstay of treatment.
And diuretics. Yeah, probably should be the mainstay in this case. And one more thing, I just want to make one more comment. You have mentioned that empirical coil embolization. I really don't know whether it is really useful, because having seen a bleed and you are actually blocking some blood vessel without knowing that that is the cause for all the problem. So it will be counterproductive. No, I don't know. I just want to get opinion from others.
Generally, sir, we do rule out other causes before going for conventional angio, and we do a CT angio usually before we proceed with the conventional angio. In this case, we were reasonably sure because it was a dunking PJ and there was only luminal bleed and there was significant hemoglobin drop, and again the FJ was showing fresh aspirate. It was very much likely that the bleed was from the pancreaticojejunostomy site. And conventional angio, the GDA stump was not oozing, it was patent, and then the rest of the supply usually is come from the splenic artery branches. So once you embolize, the pressure in the splenic artery drops, and so it helps
So
in.
it probably
There is not much evidence
You
in
think
literature
if
to support.
Prasad, I have to.
Sir.
it probably reduced. It probably stopped.
But what is the
Radhavan, just a second. Then I'll finish this and.
Sir.
So it's probably reduced bleed by reducing the portal hypertension. That's what you are telling.
No, sir.
By a
No, sir. The site
like that?
The site of bleed was probably the pancreaticojejunostomy anastomosis from the pancreatic end. So by cutting off, reducing the pressure in the branches of the splenic artery.
And just one more comment. You have mentioned that you will start them on upfront meropenem, which again I don't think it is the usual norm. Meropenem should be a reserved drug, and probably I think we should start them on third generation cephalosporin or carbanicillin, piperacillin, tazobactam maybe in the initial days. Unless there is an indication for meropenem, probably it's probably better not to start carbapenems. That's just my thought. Yeah. Thank you. Venu, sir?
Yeah, I'll take some questions from the chat box. Dr. Subir is asking whether would you have considered US biopsy and repeat biopsy in view of the high risk Whipples in this patient?
Sir, we had considered going for a repeat biopsy, but the medical gastroenterologist who did the endoscopy said that the appearance was really unhealthy and it looked really like a malignant lesion. So we went ahead and decided to explore.
Another question from Dr. Shabir Ali asking, in the era of directly acting antiviral drugs, which has a short duration course of treatment of 24 weeks, would you have considered giving them antiviral treatment, waited and then do the surgery? Probably the portal hypertension also would have reduced with the antiviral drug treatment.
Sir, even with the direct acting antivirals like sofosbuvir, the treatment duration is still 6 months, at least 6 months, and depending on the viral response, we have to continue it still further. And the thing is, if it is a malignant lesion, and with the endoscopist commenting that it really looked like a malignant lesion, we would still go for tackling the ambulatory lesion rather than going for the HCV treatment first.
Can I make a comment, sir?
Yeah.
Yeah, why I asked is this patient had a mildly elevated liver enzymes, I think. It is in 80s and 100s, had a positive viral load. I do agree in 2011, it is difficult to treat HCV. But now I think it's at least for a few weeks of treatment, whether it will, because you said the liver is hypoattenuating also. Might have had some ongoing hepatitis, and will the treatment make a difference? It's my thought process.
Also,
and another thing,
any AST level above 50 is suggestive of active disease and may be treated before taking up for major.
Sir, actually, there is no short course treatment. If we start him on anti-HCV treatment, you have to complete the treatment before taking the patient up for surgery.
Can we take in between, like few weeks of treatment? You know, it's just a thought process. I don't know whether it's
I checked up the literature regarding this. Nowhere they are suggesting that you give a short course treatment. Even though you check for early viral response, with the early viral response also they are advocating that treatment be completed for at least 24 weeks before taking up the patient for surgery. That is 6 months.
Because in HCV, what we have noticed is the liver parameters improve dramatically with treatment.
Yeah.
And another thing is regarding what we have discussed before, is it ligation of the perivascular tissue is better or using a this thing, ligashure or
Ligation.
yeah, in
Even-
cirrhotics?
Generally, ligation is better, sir.
Okay. And another thing, what is the impact of these Whipples on liver function of these patients? We always see the tumor-related outcomes because even otherwise young patients undergoing Whipple for these benign reasons, we have seen some of them coming back with worsening liver functions or cirrhosis. Some 1 or 2 patients recently we have seen some 15 years back underwent Whipples and then coming back with cirrhosis. I don't know whether it's related or not. Is there any data on that? And a cirrhotic patient, how do they behave after Whipples?
Sir, if the endocrine function is preserved and the diabetic status is controlled and your anastomotic biliary anastomosis, there is no stricture and I do not have literature data to support, sir. But this patient, after 9 years, his LFT is normal and he has a sustained viral response also. And he's having a reasonable quality of life.
We have some literature evidence that post-pancreatectomy liver dysfunction develops, and it is mainly steatosis, and patients can decompensate. Even in our series, we had 2 patients, actually 3 patients decompensated, one under liver transplant, 2 of them could not undergo liver transplant and died.
Yeah, that's why I do.
Even the transplanted patient also died because of post-transplant complications, but it is not an unusual complication. Many patients can develop steatosis, and there is no definite treatment. Some people suggest zinc treatment as a prophylaxis to prevent progression of steatosis.
Thank you, sir.
Dr. Venu, can I ask that
Yes.
risk of there's the risk of worsening of liver disease? Is it more? Is it with Whipple, or is it for total pancreatectomy? With Whipple also, is it?
Whipple also. I think probably it is loss of duodenum also is contributing to it, and its trophic factors.
So even with partial, I mean, with the Whipple, there is the loss of heterotrophic factor.
Total pancreatectomy, I think almost similar results, I think, as far as steatosis is concerned. So the common factor may be loss of duodenum, and it is loss of hormonal function from the duodenum.
I think there are questions and suggestions from our senior faculty in the chat box, sir.
Dr. Prathapan, please. Dr. Prathapan, can you unmute and ask the question? Hello? Am I audible?
Yes.
Yeah, you're audible.
Sir, can you ask your question, sir?
I don't have any questions. I just wanted to ask Fahad, what drain do you place and what is your policy as far as drain removal? I think we should keep things simple. When you operate a patient with CLD, we need to take certain precautions. Postoperative ascites is the rule rather than the exception.
Yes.
Because the trauma of surgery, anesthesia, they push the liver function, southwards. So what drain did you use, and what was your plan in terms of removal?
Sir, we had 2 drains placed. Depends on the surgeon preference.
No. What drain was placed in this case?
For this patient, we used 2 drains. One adjacent to the PJ and another near the HJ.
Dr. Fahad, when you say drain, I would like you to tell us whether it's a tube drain, whether what's the diameter of the drain, what material drain did
28 French abdominal drain.
And what is your criteria for drain removal? You must be having some plan, whether you actually executed it or not is a different thing. What was your plan as far as drain removal?
So the plan was, provided there is no pancreatic fistula, to take out the drains once the it stops draining.
Suppose
when it comes extend-
suppose I were to sort of tempt you to suggest that I would recommend an early drain removal.
If there is
And
no pancreatic leak.
if there is no obvious pancreatic fistula and there is no sepsis, I would even be willing to do a drain fluid culture if that is not growing any, invasive organisms. Then take out the drain, even go to the extent of placing a suture on the parietes to prevent ascitic leak, which would be a major step in minimizing the postoperative ascites. Whereas if you keep it for longer and longer, it's bound to get first colonized and then it's going to get infected and then it'll never be able to remove it. You said you wanted it to stop and probably it will take a long time. This patient had good liver function and probably not very severe portal hypertension. Therefore, the patient, it ended by itself, but otherwise it would have been a problem. Dr. Venu raised a very important issue about antibiotics.
Yeah.
I think RCN also said, why would you want to use meropenem because the patient is cirrhotic?
I didn't say meropenem. I would give, usually I give only 48 hours in a standard Whipple.
Yeah.
Here I would guess, say I would maybe for 5 days.
Yeah, so even then, in a cirrhotic, I think we should still try and limit the antibiotic use rather than to go on inordinately.
Some literature is available that prolonged antibiotic is may be useful to prevent a secondary ascitic fluid infection.
General,
very limited literature.
Yeah. I think in general, the overwhelming evidence is in favor of not giving too much prophylactic therapy because resistant organisms will take over.
Yeah.
And then that is difficult to manage. So it's always better to withdraw the antibiotic and reuse it as and when required, rather than to have the kind of psychological, reassurance for the surgeon. And that concept we have all tried to go away from with great difficulty. And in cirrhotics are even more vulnerable than normal patients. But I had a question, both Fahad, Ramesh and B. Venu, that everybody talked about ampulectomy. I do not think that any one of us have successfully done an ampulectomy in a patient who has no dilated ducts.
Yeah.
The presence of a very grossly dilated bile duct and a pancreatic duct tell us two things. One is that it's a slow growing process and that the dilated portion is not involved by disease. And straight away it gives you a point at which you can decide where your transection margin is, where you can decide whether your margins are adequate. In a case like this, it would be quite technically impossible to do an ampulectomy except a hodgepodge ampulectomy. And then you would then have to trust the vagaries of pathology to tell us where we were. And you would have it would be quite impossible to reconstruct the pancreatico-duodenal, the pancreatico-biliary unit back to the duodenum. So your comments, both Ramesh, Fahad and Venu.
Undilated PD, it's very difficult to do an ampulectomy and suture back the pancreatic back to the duodenum. It's very difficult.
I fully endorse that view. And regarding your discussion about ascites, I fully agree. But in this particular patient, the additional concern was that the persistence of the ascites, we didn't want at any cost to disturb the FJ. The FJ has to get the site. We wanted it sealed. Nobody exactly knows how long it takes for an FJ to get sealed, because that will be the lifeline of this patient if we take our medicines. So that is one concern. The other concern is of course the healing of the abdominal wound and this thing. So FJ was one prime concern. If you do early removal and the ascites builds up, God forbid if something happens to the FJ, we had it. So that is one of the concerns.
Ramesh, in response to that, may I suggest that we could consider removal of drains early.
Yeah.
And then placing a secondary drain if the ascites were troublesome in terms of either a 3 lumen catheter, which we could allow it to be a valve drainage, a limited drainage of ascitic fluid, which is a, which is a pressure release phenomenon to prevent your disruption of various, anastomosis. I wanted to mention also that RCN and every other member talked about post-Whipple liver disease. I think a good number of them are compounded by the use of chemotherapy. And the cash further deteriorates the liver function, and then 3 or 4 years later, the patient has no recurrence, but the patient is in liver failure. I think that's been a fairly recurring theme, and perhaps some of the patients Venu has referred to also were in this category. They all received chemotherapy. Did they not, Venu?
One was an NET patient, actually. He didn't receive any chemotherapy.
Okay. But the adenocarcinomas generally receive chemotherapy, and that compounds the,
Yeah.
Can I make a response to what Ramildran was talking about, empirical embolization, Dr. Venus?
Yes.
Empirical embolization, I think all of us know that there is hardly any evidence to support that. No evidence. We are unlikely to get it as well. But in this, the one concern was that when that patient developed bleed, definitely, I mean, the RT aspirate, a fresh RT introduced, and the aspirate was clear, and the FJ showed blood, and he had a sudden onset tachycardia, HP drop, and he had a dunking. There is no blood in the drain, so you're almost sure that the source is from the pancreatic stem. And our primary concern at that time is a person who is having a potentially curable disease, a potentially curable tumor, early tumor. We have high-grade dysplasia with us. So not to push him at any cost into decompensation. That is the only concern. So we were literally, I mean, you can say driven to the wall. And as a preemptive method, as a preemptive step, this empirical embolization was done. I'm not saying that the bleed stopped because of that. We had nothing else to do. And you agree that there is some literature, there's sparse literature. There are some publications which also say that it may be useful. And I have discussed this, we have discussed this with in and out with interventional radiologists. They have also practiced it. There's hardly any evidence, and we are unlikely to get evidence as well. So our concern was another massive bleed. If he gets a massive bleed, we know that surely he's going to decompensate.
Actually, okay, I agree with you, but the problem is that the PJ site bleed, especially in a cirrhotic patient, it could bleed from the jejunal edge also. That is the case, it will be counterproductive. So I don't, still I feel it's probably just wait for the bleeding and then probably.
So in a non-cirrhotic patient, I agree. In a non-cirrhotic patient, I would be inclined to wait maybe more if there's only Harald bleed and so-called bleed and stops. But in this person, the only concern was the cirrhotic nature. If he bleeds, if he gets a bleed, God forbid, he may decompensate.
May I just venture to suggest that although most of us feel that an empirical embolization, if at all, should be done only of the GDA stump and not of any other part, I think that's generally what most pancreatic bleeds are handled. But the fact that the patient stopped bleeding after that and then the patient is alive today throws a lot of merit in Ramesh's arguments. So I guess we just have to live with it. The question is whether he would himself do a splenic artery embolization in a future case. And that's something I look forward to observing when in a similar situation.
Fahad, do you want to answer that question?
Sir, we have around 7 to 8 patients where we have done empirical embolization, both post-pancreatectomy as well as for post-acute pancreatitis with a Harald bleed. And around 6 patients have done well after that, and the bleeding has stopped in around 6 out of 8 patients.
Now I think that's biased now.
Yeah, it's could be. It's difficult to get. I think it's basically done because the logistics of
I would say that if nothing was done, also the patient would have.
Exactly. That's what now. Now
Yeah.
the fact that there were 6 cases now lends a lot of strength to Prakash's suggestion that if nothing had been done, so perhaps a biomedia for somebody who's learning from this experience is that I would probably keep this in the back of my mind, and if the patient bled again, to immediately do a sphenic artery embolization. But no, I wouldn't do it in the first instance. I mean, this seems to be a reasonable, proposition, and RCN also referred to that approach. I think Prakash would do the same, perhaps.
Yes, sir. I think having done a conventional angiography, one is fairly sure that there is no leak and there is chance for immediate bleeding. So empirical embolization is something which is very rarely done in current day practice, I believe.
And I think we have trainees, we have young surgeons, and we have experienced surgeons. I think the message should go out that we must try and be, more, shall we say, definitive in our approach to embolization and not so empirical.
Especially if you have a 24-hour service for interventional radiology.
That is the question. So all these things varies from centers to centers. Right now we have a 24-hour service or near 24-hour service, but not in 2011.
In this patient, sir, it will reduce the portal, because we have seen this bleed from the anastomotic sites in portal hypertension patients, even in transplant patients with jejunectomies, on the 7th day, 10th day. So in this patient, it would have helped by reducing the portal hypertension also in a luminal bleed.
I had put this question in the chat box that the effect of the embolization may have been actually convoluted because of the portal hypertension reduction.
As we have one more case to go, shall we wind up? Hello? Hello?
Yes, sir.
As we have one more case to go, shall we wind up this case?
Yes, sir. Yes, sir.
So I thank everybody for the active participation and Dr. Fahad for the nice presentation. Thank you.
Yeah. Shall we start with the next case?
Yeah.
I think after a very active, difficult clinical problem, we have a diagnostic enigma, diagnostic problem now. It's a thick-walled stomach. To present that, I would request Dr. Sagar Narayan to present the case from Lakeshore Hospital. Dr. Sagar, please.
Yes, sir. Thank you, sir. Am I audible, sir?
Yes, yes.
You are audible. I am going to mute all, and you can unmute and start. You can share your screening.
So, is the presentation visible, sir?
Not
okay.
Not shared.
എന്ത് പറഞ്ഞു
അല്ല കേൾക്കൊണ്ടിരിക്കുന്നതിന്റെ കയ്യിലെന്തോ മഴ വന്നിട്ടാണ് ഇപ്പൊ ഇങ്ങനെയിപ്പോ
Good evening, sir. First of all, I would want to thank Asgk for giving me this opportunity to present the case. And this case capsule was given to me by my mentor, Dr. H. Ramesh. And the identity of the patient and the treating group has been omitted. Aim is to merely learn from the case for the academic purpose. Thickened gastric wall is always a cancer, or is it not? A 44-year-old female homemaker nearby district comes with the symptoms of early satiety since 2018, nausea and vomiting since 2018, weight loss since 2018, and dysphagia to solids just for a period of 1 month in the month of May 2020. So the history commences from the 2018. Early satiety, to describe its early fullness of stomach, quantity of the food consumption was less and it was decreasing gradually, and there were no associated heartburns, chest pain, and other regurgitation symptoms. Nausea and vomiting was from 2018 not present all the time, but it is occasional, associated with the food intake, and mainly after solid food consumption, and it is non-projectile and contain food particles. Weight loss since 2018, it is gradual and progressive. So far, she has lost from 65 to 42 kg at present. So total, it would be around 23 kgs. Dysphagia is for 1 month only from 2020 May to 2020 June. More to solid foods, gradually progressive for 1 month. The history commences from 2018. May 2018, the patient goes to surgeon 1. Surgeon 1, taking the history and evaluating her clinical symptoms, suggests endoscopy and CECT for the presenting symptoms. The first endoscopy done on March 2018 showed thickened mucosal fold in the body of the stomach, and differential diagnosis of working diagnosis of infiltrating mucosal disease was made, with the first diagnosis of carcinoma, lymphoma, and many trace disease were made. The biopsy was taken from the endoscopy, and that showed crushed atypical cells from the gastric body. The CECT done by the surgeon 1 in May 2018, there was a circumferential wall thickening of the stomach involving distal body, antrum, and pylorus. No lymphadenopathy at the perigastric region. The suspicious of Linitus Plastica. With these two reports, when it was conveyed to the patient wanted to take one more opinion before deciding on any plan of management, and she visited surgeon 2 in the same month, May 2018. Surgeon 2 evaluated with endoscopy again and PET-CT. The second endoscopy, same findings, but this time the multiple drill biopsies taken from the antrum and D1 and D2, and even then it showed crushed atypical cells. This is the endoscopic pictures of the first and the second endoscopic pictures, which shows the thickened gastric mucosal fold. Based on these endoscopy, CT, and the clinical features, working diagnosis of some of the differential diagnosis of gastric wall thickening was made by surgeon 2, with primarily giving importance to carcinoma Linitus Plastica as an initial diagnosis. Carcinoma, lymphoma, many trace disease, autoimmune gastritis, Crohn's, peptic ulcer disease, tuberculosis, sarcoidosis, and infiltrative metastasis. All these could be considered, but highly in this particular index case, carcinoma would suit much better. The PET-CT suggested by the surgeon 2. Here, if we see, there is a diffuse gastric wall thickening, but more in the gastric antrum and pylorus, with a SUV uptake, standardized uptake value of 2.8. And in this figure, there is a small 8 mm nodule with SUV of 2.2, where metastasis cannot be ruled out. This is a mesenteric lymph node, which is almost around more than 1 to 1.2 centimeters, with the SUV max 2 uptake. Metastasis could not be ruled out. At this point of time, I would like to consider what is consistently crushed atypical cells. What does it mean? We have to think about it regarding consistently crushed atypical cells. Does it mean a regeneration, inflammation, or a cancerous cell, or a normal cell, or an artifact? FNAC of the lung nodule was done. It shows clumps of inflammatory cells, alveolar macrophages, and an occasional cluster of stromal cells, which was again ordered by surgeon 2. And based on these findings, surgeon 2 also ordered EUS FNAC, which showed monolayered sheets of uniform epithelial cells. An occasional smooth muscle fragment is seen. Cell block shows small fragments of gastric mucosa with foveolar epithelial cells. Based on previous endoscopy and CT, present endoscope, second endoscopy, PET CT, FNAC of the lung nodule, and EUS, decision given by the surgeon to repeat the endoscopic biopsy for the third time. The plan was made. The third endoscopic biopsy has to be repeated. If it is positive, to go ahead with the staging lab and total gastrectomy with adequate lymphadenectomy. And if it is negative, then to go ahead with the diagnostic lab and intraoperative frozen section and proceed accordingly. Now, finally, the third endoscopy was done in April 2018, which again came negative for malignancy. Patient went to medical oncology for further opinion, and medical oncologist, they suggested, due to lack of positive biopsy and patient unwillingness for the surgical intervention, they advised proton pump inhibitors and suggested follow-up from the surgeon 1. Once again, the patient went to surgeon 1, and surgeon 1 advised them to follow up after 1 year. Just 1 year later, in June 2019, she once again came to surgeon 1, and over this 1 year, she noticed partial relief of symptoms in early satiety, nausea, and vomiting. And even though early satiety, nausea, and vomiting mildly subsided, but she had a weight loss from 65 to 55 kg, almost around 10 kgs over a period of 1 year from the time of first presentation. Fourth endoscopy, when the patient came to surgeon 1 on June 2019, this fourth endoscopy was done, and that showed grade A esophagitis, lax OG junction antral gastritis. This was a follow-up endoscopy which was done. Once again, the patient was put in proton pump inhibitors and sent back. And just 1 year later, 2020, patient came to surgeon 1 with a new symptom of dysphagia to solid since May 2020. Patient went to surgeon 1. The fifth endoscopy was done in May 2020. The previously lax OG junction was there in the last endoscopy, but at this endoscopy, it was a tight OG junction. Scope could able to negotiate it with very difficulty. Biopsy taken from the antropyloric region, that was negative for malignancy, and no biopsy was taken from OG junction. Now, since the surgeon 1 has seen the patient since 2 years, he has advised the patient total gastrectomy, but patient, due to the non-confirmatory findings of the biopsy, they wanted to consult a new medical gastroenterologist and different new endoscopist to solve her problems. And based on her new symptoms of dysphagia since May 2020, barium swallow was advised by the new gastroenterologist, and that showed a picture something like this with the dilated esophagus, a fibrotic also in the middle, and the completely contracted fibrotic stomach with a narrowed segment of distal esophagus, which almost looks like a rat tail appearance, or we can call it a bird beak appearance. A diagnosis of achalasia cardia with Menetrier disease was made by the new medical gastroenterologist, and referred the patient back to the surgeon for the management. Operation done by surgeon 1. Surgeon 1, having seen that barium swallow and the symptoms from past 2 years, considered it as a motility disorder with the Menetrier disease, and he wanted to perform laparoscopic anterior cardiomyotomy. So he did that, and the intraoperative findings were stomach wall thickened and fibrotic. Cardiomyotomy done 7 centimeters proximal and 2 centimeters distal from the GE junction, and full thickness biopsy was taken from the stomach wall. Exactly the details of the biopsy site was not given, and how they sutured it also was not given in the investigative documents available. So full thickness biopsy was taken from the stomach wall was assumed. Biopsy of the full thickness stomach wall revealed poorly differentiated carcinoma, and this time a CT was advised by surgeon 1. And CECT findings, which was done outside, no reports were there, no images were there, that showed moderately enhancing GE junction and periesophageal lymph nodes, moderately enhancing pyloric region and the surrounding lymph nodes, and pulmonary metastasis. Patient once again was referred to medical oncology in view of the new CECT findings. Morphology and IHC once again were confirmed with the pathologist, and it was poorly cohesive carcinoma of gastric origin. She was started with chemotherapy, oxaliplatin and capecitabine 6 cycles, 21 days apart. Reassessment CECT at 4 and 6 months showed disease progression. Reassessment CT 26 October 2020. A new lesion in the liver, increased thickening at the GE junction, and lung nodules means the same. This is the increased thickening in the antropyloric region, a small hypodense lesion which is exactly not visible but is there, and a small pulmonary nodule. From that was after 4th cycle, and this was after 6th cycle. This CT done on 24 November 2020 showed progression of the disease with new lung lesion, cirrhosal deposit around D2, D3 causing biliary obstruction and partial gastric outlet obstruction. This was the thickening in the GE junction. This is the dilated biliary bile duct, common bile duct, and this is the obstruction at the level of duodenum, antrum and pyloric region. Once again, the patient, based on the advanced disease, the medical oncologist referred the patient to gastromedicine department for endoscopic stenting, and OGD findings were duodenal stricture, self-expanding metallic stent was placed. The abdominal X-ray showing self-expanding metallic stent placed. And just after 1 month, stent got displaced and disease recurrence was diagnosed, and now the patient was referred to surgeon for further management. On examination,
no problem, don't follow all the rules. इंटरनेट खत्म हो गया था इंटरनेट
some audios. On examination, presently
लड़की से हो गए थे, गर्लफ्रेंड पिटाई हो गई थी वो। ए मगा मां मगा ये ना लड़ी था।
On examination, presently vomiting, not able to take food, poor intake for 1 month, 100 calorie was the intake and less than 5 gram protein just before getting admitted to hospital. Present weight is 42 kg, BMI around 16, and Karnofsky score performance scale was 70. Icterus was present. Abdominal examination, mild epigastric fullness was there, no mass palpable and no deposit per rectum. Diagnosis of metastatic Linitus Plastica with gastric outlet obstruction and obstructive jaundice was made. And the plan by surgeon 2 was palliative options. One is PTBD and a nutritional improvement in the form of feeding jejunostomy. But patient opted for a supportive care and went back to the local hospital without undergoing any procedure after knowing the poor prognosis. And the issues in this case, which I would like to discuss, and I would like to get the opinions of the respectable audiences also, are: 1, atypical cells on endoscopic biopsy. Does it need a proactive approach? How many biopsies to be done in a patient with early satiety, anorexia, weight loss, and a thick-walled stomach? How often do mimickers of Linitus Plastica get seen in GI units? Does EUS biopsy really add to the efficacy of a well biopsy? Well biopsy is just creating a deep well at the same place where more and more of a deep tissue can be taken out from the same point. Does the FDJ uptake SUV correlate with the malignancy? Does achalasia ever accompany a thick-walled stomach? Since the patient developed relief of dysphagia after myotomy, can we call this a secondary achalasia? What is the relevance of feeding jejunostomy in a supportive care palliative setting? Given that it does not palliate and only prolongs life by maintaining nutritional status. In an intent to cure neoadjuvant setting, it has every roles, but in case of this kind of settings, is there any relevance of FJ? Thank you, sir.
Thank you, Dr. Sagar. This is really a difficult scenario. I think most of us would have faced this type of patients once once or twice in our practice, and particularly in a young patient with thickened stomach and anorexia weight loss is a common presentation. And I think this patient had extensive efforts to get the diagnosis right, and one or two times he had diagnosis of atypical cells as well. So that's a very important landmark. And my comments about the PET is that most of them, they have proliferate tumors. PET uptake may not be there at the tumor itself. I would rely much upon the endoscopist impression, lack of distensibility if he feels, if it is thick walled. Then at some point of time, we may have to, maybe after 2 or 3 episodes, I don't know whether there's any literature support. So we need to consider surgery, laparoscopic biopsy as planned in your short algorithm was my proposal. And I would request all those who had experience in similar cases to put in comments in the chat box or make a comment. And this topic is open for discussion.
Yeah. Can I say something? Sudhir here.
Yes, Sudhir.
Yeah, actually, I think that if a patient has the stomach is thickened, we know that it is disease is persistently thickened from 2017 onwards. We have to get a biopsy and we have to get a diagnosis somehow. So if the biopsy is something like non-informative, we have to keep on doing it again, or as you said in the algorithm, you can go ahead and do probably a full thickness biopsy and get a diagnosis. So the point is that actually we have to get into a diagnosis. We can't just treat the patient with BPI, H2 blockers or symptomatically without diagnosis in a thickened stomach. One more thing which I want to say is at that time itself, the stomach was thickened, the whole stomach was something in the barium meal known as Linitus Plastica. So is it a poorly cohesive carcinoma from 2017 onwards? If it is like that, would the patient live for 3 years and that a poorly cohesive carcinoma? Or is it a lead time bias? Even if you intervene in 2017 itself by doing a total gastrectomy, the usual lifespan of this patient is probably 2 to 3 years. So is there any lead time bias in this case?
Yeah, those are very valid points. But some patients to pull on without much deterioration for quite some time, they have only anorexia and weight loss. Dr. Subilal was suggesting to go for diagnostic laparoscopy and biopsy. That's a very valid suggestion, and a lot of chat box comments with experiences. I would like to invite comments from Dr. Ramesh and Dr. Mahesh, who were primarily managing, probably was part of the management. I don't think they were not doing much of the management except for seeing the patient. Sir, please.
Well, since Mahesh has nothing to say, I just think I don't think we see many benign instances of thick wall stomach, and I feel this is a good instance where the members of the Asgk must put into a database all the thick wall stomachs where the eventual biopsy turned out to be autoimmune gastritis or Menetrius disease or some benign form. I think they are so rare that we should document it. So if it's a thick wall stomach, it's just, if it's Tuesday, it is Belgium. It is definitely most likely carcinoma, and common things are commoner. As Dr. Gangadharan pointed out, if you thought there is lymphoma, which it is quite justified, but there should have been extragastric lymph node involvement. Something must have been seen on CT scan. You can't get a lymphoma just in the stomach with nothing, with such an extensive thickening of the stomach. That's also super rare. And the FDG PET also uptake would have been higher. It's only in signet ring cell carcinoma typically that the SUV uptake will be so low. And I think Arsen's point that diagnostic FDG PET is really of no use is true, except if there's metastatic disease. This metastatic disease, it is a clincher. So we have done. I think the surgeons and the physicians involved in the patient kept pandering, it seems, to the patient's preferences and the questions. Nobody probably really told them. I think once the patient actually saw a surgeon who told them that I think surgery is the answer, you need not think further, but they did not consider that, or they went for another opinion. Dr. Sudhir's point, though cannot be discounted, we do not need to consider it like that, because that can only be proven if a resection had been done at that time and then there was no malignancy, or even if there's malignancy and you diagnosed it earlier, you may have given better quality of life, because the patient has had pretty much a dismal quality of life during the entire period of her life after 2018. So, but is this really a secondary achalasia? You hear so much about it, but I've never seen a case which has been handled by myotomy. And that's another reason why I thought Dr. Sagar should present this case, because this is a wonderful situation of an antropyloric pathology extending to the rest of the stomach, but presenting at some point, and it all happened only because there was no intervention earlier on, with esophageal dilatation, and the patient's dysphagia actually improved after the myotomy. So there's this, remarkable situation where you have a body biopsy which finally clinched the diagnosis of cancer, whereas the dysphagia per se, albeit maybe temporary, has been relieved. So this is probably one of the rare cases of secondary achalasia. It emphasizes the fact that I don't think any of us has seen an achalasia with a thickened wall stomach. If we see it, perhaps it's time to reconsider that the diagnosis may be something else. And finally, I wanted it to be emphasized that if a patient comes in with a failed stent, you can do something endoscopically to restore the pyloroduodenal obstruction, clear the pyloroduodenal obstruction. If you thought there was enough stomach remnant, you could do a bypass. But to do a feeding jejunostomy would be morally and ethically incorrect, because you would just prolong the life without relieving the patient's symptoms. And that was an equally important principle that we should learn from this case. So there's many, many morals from this case, but I think if it happens again, each one of us should sort of take care to see that we just have to do at least a diagnostic laparoscopy, at least a full thickness biopsy, or at least you can do even a core needle biopsy under laparoscopic guidance, wait for frozen section, and proceed. In other words, do more, and then we may be a little more safe. Those are just some of my comments.
Thank you, sir. Dr. Ramesh Rajan has commented that they had few patients who had thickened stomachs, but ultimately they turned out to be benign. Were they of this type of uniformly thickened stomach?
Yeah, it
like
was.
Linitus Plastica, or?
It was, but I'm not batting for that. I would still take the stomach out of people walking around with multiple biopsies, getting nowhere. One was a menetrious disease with superimposed dysplasia, so, biopsy report of dysplasia, and we proceeded with total gastrectomy, but there was no malignancy in that. And the other, surprisingly, turned out to be a Crohn's of the stomach. But
actually, I would recommend that we make Dr. Mahesh and Dr. Sagar do a survey of the Asgk, design a survey and get details of all these cases, and perhaps it should be yet another publication from the association, because this is obviously important information. I think the only real proven cases of benign are those which underwent resection, and at the end of the resection, they turned out to be benign. I have patients who have had autoimmune gastritis, where we finally had to resect the stomach. But I don't have a Menetrius disease on the resected group. So I think it will be interesting to get everyone's data.
Hi, sir.
That's a good suggestion.
Shabir here, sir. Yeah. Hello.
Yeah, hello. Yeah, tell me.
Yeah, sir. Two doubts. One is regarding the use of immunohistochemistry when you get some atypical cells on endoscopic biopsy. Is it really useful in this situation?
Probably the pathologists have very little material to look upon, so I don't know whether that's going to be helpful. Unless the tissue yield is good, they may not be also comfortable to comment upon and finally to give a definite diagnosis.
Okay, sir. Yeah, second one, we had two mimickers recently. Both patients had, one had a gastric outlet obstruction and the other had a diffuse gastric wall thickening, and both had on CT some peritoneal disease also. And when they were referred for chemotherapy, our oncologists usually ask for a PET scan nowadays in all patients. So both had a breast lesion picked up. Young ladies in 30s and 40s, both had breast lesions picked up, and final biopsy came as lobular carcinoma of the breast. It came, these two cases came together, maybe nearly in a 1 month gap. One presented with gastric outlet obstruction and the other presented like Linitis.
Dr. Shabir Ali, Dr. Aravind has published a case where bowel metastasis has occurred from lobular carcinoma of the breast. So he's actually published it from our department.
Okay, sir.
So if Dr. Prakash, if I can put it this way, so most of us, the surgical side, feel that you don't need a definite diagnosis, a biopsy of malignancy to do a major resection, correct? Is that
No,
right?
I would put it in this way. Maybe my threshold will be 2 or 3 biopsies, and if all
and
of
you
them
don't
are
need
not conclusive, then I would suggest a laparoscopic and full thickness biopsy of the most suspicious area, and then proceed rather than for upfront resection. If frozen section is available, that may be a logical step. If frozen is not available, then you'll have to discuss the pros and cons with the patient and then plan for a total gastrectomy.
Yeah, correct. So as Pidambaran has mentioned, always that even the diagnostic laparoscopy biopsy may not give.
It has to be full thickness biopsy.
Full thickness, of course, it will yield more than the endoscopic biopsy. I agree. But I'm talking about the situation where all biopsies are inconclusive. We don't have a definite. What I'm trying to say is, if I think all of us know that the oncologists, I think the national body, the society has decided that they give chemo only if they get a tissue diagnosis of malignancy. I think the same applies to radiation also. Whereas most of us surgeons are more inclined to do major resections, and of course in HCC and that is a norm in the liver lesions. So even if you don't have a tissue diagnosis, you are quite happy doing a major resection. Whereas oncologists need a biopsy. Of course, I agree that you need typing, subtyping to decide on the type of chemo, all those things. But there is a difference in the thinking of the among the oncologists, the society.
Dr. Ramesh, I have a slight disagreement with you because with the advent of SBRT and such methods for treatment of HCC, now radiation oncologists have departed from the principle of requiring a biopsy. Many of these lesions have not been biopsy proven. They have AFP positivity, high AFP levels. They have typical imaging characteristics, and then they have been quite able to accept it. Similarly, medical oncologists have many idiosyncrasies, They may, they're based on anecdotes. They may, it's quite justified for them to say that a proper biopsy is mandatory because long chemotherapy regimen may be required. But most centers or many large centers want biopsy from their own center. And that is usually one of the prerequisites for starting chemotherapy. And that sometimes carries things too far. And so all these, we need to learn from the case. We need to understand that it is important to get a biopsy because why was it negative? Nobody is asking the question, why was this repeatedly negative? Could it be that it's not cancer? That question obviously occurred in the thought of the treating doctor's minds and the patient's minds, and that's why it got delayed. But logically, it should have been operated, as Prakash said, as you said, as everybody else said. But so what could have been done? We should have done laparoscopy. We should have done full thickness biopsy, which brings me to an interesting question. I don't know how to do a full thickness biopsy in a thick wall stomach, either laparoscopically or open, and how would I close it with any kind of reliability? I haven't done a thick walled full thickness biopsy. Perhaps Ramesh, Prakash, whoever it is could tell us how to do it. And if you close it, do you really think if there is cancer or if there is specific disease, the suture line would heal? Would you get a gastric fistula? I don't know. I would much rather do a wide bore needle biopsy, core biopsy using a biopsy gun. I would take several and then just reinforce it with a figure of 8 suture if required. That would be preferable to me rather than to do an incision biopsy. So I'm curious to know how it was done. If somebody knows how to do it, they should tell us how to do it.
I agree with you. I think
regarding full thickness biopsy, we had 2-3 situations like this, and we had done laparoscopy, but luckily there were some nodes with film omen. We could get away with that. We haven't done any full thickness incision biopsy of the stomach wall.
Would you consider doing a biopsy gun biopsy, Prakash?
Maybe that's a wise idea. That's a better idea, I think.
What is your experience with that?
No,
What is the yield like?
Well, you don't have a denominator, Dr. Ramesh Rajan. So we cannot, when we say this is an exploratory approach, because this is not a common condition, but I think times without number, when we have seen a thick wall stomach, this case came to us at once at the very beginning when we advised surgery, and then the patient disappeared. And then recently with all these obstructions where we talked about palliation and the ineffectiveness palliation, and then they went away again. But I took this case to our medical oncologist, Dr. Gangadharan, and he was quick to say that this is a patient who also should have been operated because he would not think it's lymphoma because CT scan did not show any other lymphatic disease. And the low FDG PET was a useful thing. He said because it has low FDG uptake, and that suggested that it may be a poorly differentiated or a signet ring cell carcinoma. And he said definitely you should have operated the patient. That's what his suggestion was. I mean, that's coming from a medical oncologist. It's significant, and that's a learning experience for me.
Sir, there was a positive node in the lesion in the lung in the initial CT, any PET CT itself.
Yeah, maybe Dr. Sagar wants to answer all these questions. We have, I think, sidelined him.
As the surgeon too did the PET CT, there was a 8 mm lung nodule, which is not suggestive, but with a SUV max of 2, but metastasis could not be ruled out, and FNAC was also done, and that was normal from the lung nodule.
Okay, I think if there are no more questions, shall we wind up? That is a very thought-provoking discussion and a lot of learning points from such a difficult case. And one more last question is about the role for EUS. I think EUS definitely has an additional edge. It again depends upon the experience of the endoscopist and how much they spend time to get the correct zone to target and do a well biopsy. I don't know anybody else has more comments on EUS.
And if they do that properly with on-site examination itself, probably.
Yeah, correct.
This patient did have US, by the way. I hope Dr. Dominic Matthew has noted that the patient did have US guided biopsy, which also was negative.
So I would like to thank all the participants and Dr. Sagar and Dr. Rebisa for this excellent case, and hand over this to the organizers. Thank you.
Thank you, sir. Thank you very much.
I think Dr. Joshi is the president in the. Dr. Shravan
Yes,
has raised his hand. He want to ask some question, it seems. Shravan, please unmute and ask the question.
Sorry, sir. By mistake, I pressed. Sorry. Thank you.
Okay. Dr. Joshi, John?
Yeah. Sorry, I was a bit late in joining. I was held up with the case, but actually a very good discussion going on, though a bit too lengthy. I think based on, I don't know what the opinion of others also is, but I still would feel that one case will be better than discussing two cases, so that we can, because the discussion in most of the cases that we have here is usually very good. And I think it would be better that we stick to one case so that we can finish off within 1 hour or 1.5 hours.